flip up here. Okay. Are we live, Dennis?
Yes, looks good.
Cool. Well, guys, thank you so much for having us. I think we love this opportunity to talk about our program because I think John is one of the founders of the program, has worked many years to build this, and I joined 4, 5, 6 years ago to kind of, from a surgical standpoint, kind of take it to the next level with us. And we're excited to do these kind of presentations together. No financial disclosures, unfortunately. And this was us a couple of years ago, back in my longer hair days. But we direct the program as a team standpoint from the surgical and from the medical side. A couple objectives today. We're going to talk about the program and how it plays a role in the management of these super complex kids that come through. And really the magic of putting the pediatric, surgical, and the medical teams together in both the ambulatory care side and in the surgical approach side. And then the dynamic of how that affects kind of RVUs and billing on a personal standpoint is impacted, but how really the system benefits from a multidisciplinary approach. I think when you look at it from a larger scale standpoint, there's a really good argument to make for these types of teams. And hopefully this can be applicable outside of just an aerodigestive program, because I know many of you are looking to build programs, whether that's in sleep, whether that's in rhinology and complex skull base, or other kind of programs. The ability to partner with people outside your own section, outside your own institute is key. And sometimes that means an individual institute has to take a hit financially for the larger organization to save money. And I think that's what we've kind of found here, and provide high quality care. So I'm going to hand over to John in just a second. But before that, I'd like to introduce you to Caden. Caden kind of gives an idea or a flavor for what we do in our clinic and why it's so important to have teams like this. Let me show you a quick video of one of my favorite patients.
When you have a medically fragile child, other parents cannot completely comprehend how often you're making trips downtown to see specialists.
If you could imagine, at one point, he had probably 6 to 8 doctor's appointments every month. And the Cleveland Clinic said to us, well, we're trying something new. It's called the PCAVS clinic, where you come to us and all the doctors come to you at one time. So they all get the same snapshot of Caden and the way he is right then and there. That whole team of doctors at the PCAVS clinic and seeing him all at one time and seeing him on a regular basis is what has helped him grow.
Dr. Hopkins is an optimist. He knows the medical plan, and he's like, let's pursue this avenue. And so I have a lot of trust in him.
Dr. Hopkins really pushed Caden to grow, and is actually part of the reason why Caden's got his strikeout, because he firmly believed that Caden was strong enough.
He's a normal, happy, healthy little guy otherwise, and having...
So again, I know they were saying Dr. Hopkins, but I'm a small part of the kind of team that moves these kids forward. And, our PCAVS, it stands for Pediatric Center for Airway, Voice, and Swallowing. This is our version of Aerodigestive team. So when you see PCAVS referred to in the clinic, that's what we mean here. So I'm going to hand it over to you, John, and you kind of take it from here.
Well, thanks, Brandon. And thank you all for letting the non-surgeon carpetbag on your program here today. The inception of this program preceded Brandon by a couple of years. Paul Krakovitz, his predecessor, and I, basically shortly after I came to the clinic, we're standing in the OR, having tried to coordinate and having our administrative staffs spend an awful lot of time trying to coordinate simple procedure where we wanted to do something at the same time in a single OR. And I think we looked at each other and we said, we recognize the need for the service coordination beyond the OR into an ambulatory clinic and then actually into a program. So we'll almost use the clinic and program interchangeably, if you will. But this evolved into a specialty version of the medical home. And the medical home model is something which is really being pushed by the American Academy of Pediatrics. And it takes a population health approach in an effort to try to keep kids out of the hospital, optimize patient and family quality of life.
I don't even know what.
As Brandon said, there are other programs that have taken off here within our institution, such as pulmonary hypertension, which combines cardiology and pulmonology together, craniofacial, which is plastics, ENT, pulmonology, oral and maxillofacial surgery. So there are a lot of different combinations, permutations, I think, that can benefit from this. But as Brandon said, we have to be aware of our RVU productivity and everything like this in a busy market. And I think we want to go ahead and show you how we think this, some of the uniqueness of our program. Next slide. And so our program participants, really the first thing to mention is that this is an advanced practice provider, a nurse practitioner directed program. And the top panel is Annie Banas, who's our nurse practitioner, who really is the glue that holds everything together, I think. but it involves pulmonology, of course, ENT, gastroenterology with nutrition, physiatry, respiratory therapy, speech, social work, and care coordination, which is part of, in the administrative part, the nurse practitioner care and care coordination is kind of now administratively under pulmonology, but it's very ecumenical. So all these groups get to add to the program. Next slide. And so what are children, or who are children with medical complexity? These are kids with chronic medical conditions. The conditions result in long-term functional limitations who often have technology dependence of some sort or another. These substantial family identified service needs that go beyond what a primary care office could possibly provide. And these children, although comprising a very small number of the overall pediatric population, have significantly higher healthcare utilization. I think Brandon will show you some data later on. And about a third of total children's healthcare spending is spent for children with complex medical needs. A half of all Medicaid spending on hospital care and a quarter of all inpatient hospital bed days. 40% of all hospital deaths occur in this very complex population. But the most important thing is our NICUs are getting increasingly skilled in terms of saving children at younger and younger gestational ages. The number of these children is rising annually by 5%. So this will comprise an increasing proportion of the patients that we all see, both medically and surgically. Next slide, please. In terms of Medicaid spending, this is some hospital data from Ohio from a couple of years back, but the overwhelming majority is spent for hospital care. There's a fair amount spent for outpatient subspecialty care, but when we coordinate this together, we can try to drive this down. Unfortunately, a very small amount in the red box there you can see is spent in primary care, but a lot of overuse of emergency and hospital-based medicine, I think, is really what we are recognizing, and a precious little amount is spent in primary care. And I think really what I'd like to emphasize is that the outpatient subspecialty and primary care really need to share this. And our model is not to go ahead and take over the primary care for our patients in our program, but is to partner with the community-based pediatricians. Our patients come regionally, and we can't possibly provide the primary care component of this, but we need to go ahead and have a uniform communication back to the primary care physician in the patient's home community. Next slide. And so the Academy of Pediatrics has really pushed this patient-centered medical home with the goal of providing quality care in a cost-effective manner. This model of primary care is the kind of criteria or the benefits are, it provides accessible, continuous, comprehensive, family-centered, coordinated, compassionate, and culturally effective care. Now, these are, aspirational perhaps, but they're also things that really can be put into play. The desired outcomes that, again, to reduce hospitalizations, reduce ED visits, increase outpatient visits, that combine specialty and both medical and surgical care in conjunction with primary care, and overall to improve quality of life and patient experience. Next slide. And so we looked at a kind of initial cadre of about 112 patients rather, and we looked at the number of days per month, and it was just under about a day a month, 0.81 days per month for a 12-month period for our patients in this cohort prior to, in the 12-month period prior to PCAVS development. And in the 12 months following, and the patients did this, we saw a 70% reduction in inpatient observation bed days for patients. So there's a mean of 6.8 fewer days per year per patient, which of course translates to a substantial cost savings for third-party payers and for a Medicaid program. Next slide, please. And so the primary medical care challenges for the primary care physician, it's difficult for the children with medical complexity families to get the services they need. For primary care doctors, these are very rare conditions, and they're, need to have only short appointments. The subspecialty pediatricians, like the medical folks like myself, have variable access. Cardiologists have one clinic set and we're spread across a number of sites. Pulmonology the same, gastroenterology the same, and each has a single organ focus. But what's really needed for these children with complexity is that we integrate the viewpoint and kind of also have a timestamp so the patient is seen by all providers under a single at a single time, so that I see a patient at the same time my gastroenterology colleagues, because if they get an appointment 3 or 4 weeks down the line or 3 or 4 months down the line, they may very well be seeing an entirely different patient and getting an entirely different impression. So families spend, without this, they spend considerable time communicating between the various medical specialties, trying to assimilate recommendations for various medical and surgical providers. They spend inordinate amounts of time coordinating appointments at academic medical centers, as well as trying to coordinate surgeries, addressing insurance and financial issues. That's a huge burden for families. And then, of course, we order lots of these therapeutic activities that are heaped upon the ambulatory management, as well as the inpatient hospital bed days they have to deal with. And certainly, having a care coordinator, social worker, and dietitian, these resources are available within the academic medical center, but are rarely seen in a primary care setting. Next slide, please. So the traditional academic medical center has many pitfalls in providing care for these complex children. They have inadequate home caregiver support that has profound negative effects on the family functioning. They have frequent and/or, as was said by Caden's parents, or extensive travel to receive specialized care, which provides a huge stressor. Their family financial considerations. So 50% of the children with medical complexity families report that one family member has to stop working to provide care to their complex child. And with the current 2023 federal poverty level for a family of four being $30,000, that may go a little bit longer in Cleveland, but not than LA, but not much further. And so to be able to have somebody removed from the workforce to provide income for that family presents an incredible financial challenge. And these multiple factors, the financial, the coordination of care, if we don't have an integrated program, provides to really toxic caregiver stress, episodic disconnected care, conflicting management plans, and insurance gaps and barriers really provides an ongoing level of high stress for families. Next slide, please. And so the family patient-centered care coordination, integrating across multiple systems, we want to permit, it allows for coordination of integrated services. The efficacy has been demonstrated for primary and children with special healthcare needs, which is kind of a step down from the children with medical complexity. They may have only one or two organ systems that are involved, but these complex children that span many medical and surgical specialties really is the focus that we're trying to look at here today. And we look at the comprehensive patient and family needs, trying to reduce the fragmentation of care, decreasing healthcare costs, and improving experience. There really is, as of yet, very little research on coordinated specialty care for these children with medical complexity. And that's the wonderful thing that Brandon and I have worked with our individual groups to go ahead and try to look. And I think you'll be seeing some literature coming out of this group, because as opposed to strictly a surgical model, ours blends that surgical model with a medical model, a specialty medical model that reaches into the community and partners with primary care. And I think that's the distinction of our program from many other aerodigestive programs nationwide. Next slide, please. And so our APP is our program coordinator. She conducts a pre-visit about 1 week prior to our office appointments. She collects all the interval history for us from the prior visit, collecting questions and the concerns from the parents themselves. We have a pre-huddle, a virtual pre-huddle, to review that data just in the morning of the appointment or at the beginning of the afternoon session of, and it increases patient satisfaction. It also makes our visits far more efficient. The next slide will show that the kind of the flow. Next slide. Yep. The APP visit 1 week prior, identify parent concerns, and we can mobilize resources prior to the actual clinic visit happening. We do for the morning, we have a pre-huddle, and then we meet over lunch after the clinic visits. We have the post-huddle for the morning patients and the pre-huddle for the afternoon half day. And then at the end of the half day, again, a post-huddle, and then the APP and care coordinator have virtual follow-up, almost entirely virtual platform for interval management prior to the subsequent visit occurring, say in 3 or 2 or 3 or 6 months, whatever the interval decided by the group is. Next slide. And so patients are roomed and our providers rotate, as you saw in that little video clip. The therapy appointments really parallel the medical discipline. So I have a respiratory therapist who comes to handle trach or vent changes, to handle pumps and monitors. ENT has speech to partner with for swallowing and for looking at ongoing speech with kids with trachs. GI has nutrition there at the same time. Physiatry provides an integrative thing for all the therapy needs that are not necessarily specific to speech or to RT. Our care coordination goes on, monitors equipment and nursing needs longitudinally, and these procedures are completed, minor procedures, such as trial of new vent settings, nasal endoscopies, tracheostomy, trach changes, G2 button changes also performed there. So we can do a lot of comprehensive things in a single 3-hour to 4-hour half-day visit. Next slide. And so this combined and longitudinal management that we have, next slide. And so we can go to the next slide, Brandon. Yeah, we don't need to focus on this too much. And so for us, the flexible bronchoscopy in conjunction with Brandon's rigid scopes, we really need to have a different, we have approach from different vantage points, if you will. Anesthesiologists get very nervous when patients are moving, coughing. They always want to push propofol, but we must get them, and we have to work with them to understand our goals and have them be comfortable with allowing the patient's airway to obstruct, so we can see what level of degree of obstruction is seen and documented accurately. So the bronchoscopist, the flexible bronchoscopist, anesthesiologist must work together. Anesthesia can contribute to diagnostic errors by inappropriate airway management, sedation that's too deep or not deep enough. Next slide. And so our goal is achieving understanding of the patient's not only airway and anatomy, but also the dynamics, and occasionally to obtain appropriate specimens. We must assess the dynamic changes because this depends on changes in transmural pressure or flow dynamics at various levels of the airway. We can go ahead and have positive pressure ventilation during the rigid bronchoscopy or via LMA, but they will to obtain any therapeutic and interventional things, but that obscures most of our dynamic airway issues that we as the pulmonary team need to deal with in the interval between the subsequent aerodigestive clinic visits. Next slide. And so the tenets is that we don't want sedation that's too deep because we can't see tracheobronchomalacia. We may not see laryngo or pharyngomalacia. We may see pharyngomalacia, glossoptosis, or laryngomalacia that doesn't occur naturally. We have to look in the appropriate place under the appropriate set of conditions. And although we work together, I think pretty seamlessly, we approach the airway with very different perspectives and goals. The combined rigid and flexible evaluation is most often the most thorough way to go ahead and assess and then have subsequent management of airways of these patients. Next slide. So serial flexible bronchoscopy informs our pulmonary management decisions in terms of strategy for ongoing ventilatory support, for long-term airway clearance strategy and what the regimens are going to be, development of granulation tissue, dynamic or anatomic obstruction. Certainly Brandon is the one that does the therapeutic interventions, but it's very important to see as this evolves how we manage the patients to allow them to grow so this may be a safer or a procedure done as they are larger, and to work with Brandon and his team to go ahead and proceed towards possible decannulation. Next slide. And so we've got the central coordination between our medical and surgical teams of trachs, ventilators, airway clearance management. In the next slide, the multiple forms of our airway clearance with cough assist, intrapulmonary percussive ventilation, positive expiratory pressure techniques, high frequency chest wall oscillation, more frequently referred to as VEST, and other devices that may go ahead and assist with maintaining the patient until surgical intervention may be warranted. Next slide. And Brandon, take it away. Thanks very much.
Okay, John, thank you very much. And I think, you know, the reason we really wanted to partner on this is because so much of what we do in these populations isn't just necessarily surgical. And one of the other team members I wanted to highlight here is the addition to the team over the last couple of years has been speech, or not speech, but social work. I can't tell you how big a difference it has made on our team to have somebody micromanaging the social lives of these families outside of the clinic and the hospital setting. So many of these people have just struggles in their life that I couldn't comprehend and I don't understand. And being able to have somebody that does understand that and has resources for them has been very helpful. So where I'd like to start is just kind of with a general perspective. So many of these patients enter our system after they've had a tracheostomy. But I think it's interesting. Our model has evolved so drastically over the last 20 years since I started residency 16, 17 years ago, and in Cincinnati, where so many tracheostomies were performed and so many children had tracheostomies that were otherwise normal children, normal neurologic kind of kids that if you take the trach out, they're normal kids. Everything has changed in the 16, 17 years from my practice and how I've seen this evolve. We don't have as many of those normal, kind of developmentally normal children without other issues, which is a testament to our ICU care and our PICU care with less ventilation days, smaller tube size, managing the ventilation on these kids. And now even more so, with bubble CPAP, many of these children don't get intubated and they don't end up with tracheostomies. So what that leaves is the children with more neurologic consequences, epilepsy, cerebral palsy, syndromic kids. So it changes the focus of our clinic a little bit. Instead of a primarily surgical driven animal, it's a much more broadly based complex care, lots of surgical interventions, but the goal sometimes isn't always towards decannulation. And we'll kind of walk you through that a little bit. Obviously, there are still tons of arguments for tracheostomy. We do all do this on a day-to-day basis, and we understand that if it was our own little one, a lot of times we're not going to have that endotracheal tube in forever, and sometimes a tracheostomy is the right option, but not without consequence, right? There's lots of complications, lots of risks involved. I think if you read the literature right now, the current rates of tracheostomy mortality are quoted at 0.5 to 0.2%, but I think that's drastically under attributing how much mortality there actually is. If we just looked at all the National Kids Inpatient Database data over the last couple of years, and the mortality rates are drastically higher for our neonates in the hospital. 13% for neonates, 8% for infants. And this is all hospital admissions. So after you place the trach, this isn't just at their original placement. Within that, age range, this is what we should probably be quoting families, not that 2% death rate. 13% for neonates and 8 to 10% for infants, which is much higher than anything I ever knew before looking at the data a little closer. And the cost, like John alluded to a little bit, is very high. These are the costs for an inpatient stay for a pediatric patient with tracheostomy. This isn't the initial trach in isolation. It's all comers. Anybody who has a trach, if you have an inpatient hospital stay with a median length of 1.7 days, $400,000 mean for the hospital visit, which is crazy to me. And many of these kids can be intubated across the United States multiple times a year. So that's $400,000 every time they get hospitalized, which is pretty crazy. Not only that, the quality of life impacts on a personal and a family standpoint are really high. Trach is a huge burden for families. You have to have nurses in the house. You have to have ventilators. Sometimes you have to have, it's hard to travel. You can't throw this person in a convertible car and just drive to Florida if you want. And unless you're specific patients in my clinic, you can't do that. That's considered positive pressure ventilation in Cleveland, is a T-top with driving down the highway at 70. Moderate distress, mental health consequences, and something we don't have documented well in the literature is separation and divorce rates. I think anybody who takes care of these populations sees on a firsthand basis the trauma that the family dynamic has in having to deal with these super complex kids. We have houses with other caregivers in the household 24 hours a day. The infidelity rate is unfortunately higher than we'd like. Lots of complications that we'd like to avoid. So when we look at these patients, we want to start way before the tracheostomy is placed. This is just an example of like kind of a fetal care evaluation prior to consideration of airway management and trach. These kids come with lots of kind of interesting, unique situations, and the caregivers come with unique situations. Some of them have, poor social support, different educational levels, different medical levels. So the model we've evolved to at the Cleveland Clinic is really a care pathway approach or a practice guidelines approach to tracheostomy. Instead of reinventing the wheel every time a patient may be a candidate or may need a tracheostomy, we've tried to standardize this model. So standardize the discussion points for providers, and then make sure everybody is on the same page with us before we move forward. So the process that I think is really evolving for us and helping is identifying when a family may be a candidate or a patient may be a candidate for a tracheostomy, getting all the consultants involved that may need to be involved. Instead of just calling my service line for a surgical procedure, we get pulmonary involved because they're going to need long-term ventilatory support. We get our complex care team who's going to deal with some of the medical management postoperatively, our palliative care and bioethics and social work team, so the families truly understand what the consequences of a tracheostomy are. And then we have a multidisciplinary provider meeting. At this provider meeting, we talk about indications for trach, why are we doing it, what are the functional aspects of the patient, what performance category are they in, what's this kid's neurologic status. Is there, what's going on? What's going on up there in terms of where are they at neurologic wise? What's their prognosis? Is this a progressive prognosis? Are they recoverable? What are their needs in the future? Are they going to need a trach? Are they going to need a G tube? Are they going to be able to be decannulated or not? After we really kind of unpack that and get a kind of documented formalization of what's this kid's long-term potential, then we move to the family as a unified force to let the family know all the different options and what it's like to live life with a tracheostomy and whether that's the right choice for them. And we have a great example just, recently where we provided this family with all this information and they made a decision of not to move forward with a tracheostomy, which, 3 or 4 years ago, I wouldn't have known how to deal with that from a standpoint of, we're not offering something that I clearly can do to prolong this child's life. I think we're moving past prolonging life for every child and more to how do we maximize quality of life? How do we maximize the family's quality of life and look at it from a global situation? Because really, tracheostomy is a huge deal. If you place a trach in a child and then come back and talk about regret and talk about divisional conflict, so many of these families, 90% of them feel uninformed and pressured to make a decision. And in most institutions, that decision is pressuring to place a tracheostomy because we as caregivers don't know how not to do stuff. So this process helps us be comfortable with that as caregivers as well. And if you look at that number, it's pretty crazy. 2 weeks after a trach, 52% of families report regretting placing a trach, 72% at 3 months, which is unacceptable in my mind. You want to make sure you're all on the same page because we've had many patients in clinic that feel like we pushed them into a decision that shouldn't have been made, and that's clearly not what we want. So, now that we've decided to place a tracheostomy, what do? We've decided that this kid has a trach, and as soon as we place it, how do we get it out? Can we get it out? Can they be decannulated? How do we move in that direction? If they can't be decannulated, how do we optimize their quality of life or optimize their safety? And the first step in that is our inpatient tracheostomy rounding team. So after surgery, we've kind of hijacked a lot of Texas Children's efforts with Tiffany Rayner, who's a great partner who trained in Cincinnati a couple of years before I did there, but I know her very well and work with her in the Global Tracheostomy Collaborative, where we've standardized our kind of post-operative management of these kids. This is actually one of her patients, not mine. And where Velcro ties, Meplex dressing. If you take home one thing from this lecture, please, when you're placing the stay sutures on the tracheostomy tube, don't place them all the way lateral on the flanges. Place them as close to the tracheostomy shaft as possible so there's not as much play. The amount of neck breakdown, adults or peds, can be drastically reduced by doing that. So that's my one soapbox for the day. But our tracheostomy rounding team, we see these patients twice a day when it's a new trach, either the whole team or the otolaryngology service line. And then our rounding team sees them serially on a weekly basis. Every child that's in the hospital that has a trach, you get rounded on by otolaryngology, our APP team, and our speech team, and our social worker. So and this is not just our tracheostomy patients, but this is our entire aerodigestive population. Any of those kids that are in the hospital are seen by this tracheostomy rounding team. And they're really the bridge. The outpatient service line is ran by our aerodigestive clinic, but the bridge between outpatient management, inpatient management, and our rehab hospital is this inpatient tracheostomy rounding team. And it's been a delightful addition to the program because really it smooths those bumps out for families once they leave the hospital. And this is kind of that kind of global look at what this looks like. It's not just the surgeons, it's not just the pulmonary team, it's inpatient management, our rehab hospital, and ongoing program development. We also break out every 3 months. We break out a half day of afternoon where everybody is in the same place at the same time to unpack the problems with our clinic, how to make it better, and how to continually improve our aerodigestive program. So what do we do on a day-to-day basis? Our aerodigestive follow-up, when we see these patients in clinic, we a lot of times are going to look at their vocal cord movements. We're going to plan when our next joint airway evaluation is. We're going to ask ourselves, are they capping? Are they speaking valve? What's their voice potential? Do we need sleep studies? How do we incorporate that into our management? And can this patient be decannulated? Clearly, there's a lot of stuff that goes into that. We're not going to get into the weeds of that today, but these are the kind of questions that we're asking ourselves. Like, how many ED visits do you have in this last year? Are you really ready to come off a ventilator? Because the last thing I ever want to do is take a trach out of somebody and have to put it back in 3 to 6 months later. You know, that doesn't look good on my resume. So we're not going to do that if we can help it. So when we do an airway evaluation, it's also important. There's a lot of debate out there in the country about how often you should be taking these kids to the OR. And our management is really divided into two populations in my mind. Are we decannulatable or are we not? If we are not decannulatable, our SMA, our spinal muscular atrophy, central hypoventilation population, long-term cerebral palsy, undecannulatable patients, it's more about safety. How often do you have to take them to the OR to ensure safety? And ensuring safety in my mind is making sure they have a patent airway above the trach and making sure there's no erosion to the tracheal wall below. So some kids in that population, it's every 2 years. I don't have to see them in the OR every 6 to 12 months. I can sometimes take their trach out in clinic, do a retroflex, look at their cords from below and above, and I don't have to go to the OR as frequently. The population we take more frequently are those either having complications or problems, or those that are actively planning decannulation. And those are the ones we're going to kind of push to the OR for a joint team evaluation with myself, Dr. Carl's team, and the GI team. When we go to the OR, you know, we have a couple goals in mind. One, we want to minimize our time to get them to the OR so these families aren't waiting for a whole lot of, you know, in terms of getting everybody in the same place at the same time. And this is a huge testament to our OR scheduling team who bends over backwards to try to coordinate these things. One of the best things you can do to make that happen is designate 1 or 2 days a month that are your joint operative days. That way it kind of like narrows their focus of the days they're looking to coordinate these cases, and it makes it much more streamlined. We go out of our way to limit anesthetics and combine procedures. We bring everybody in the OR together, and then we come up with a combined plan. You know, much like you guys are doing, we will do an airway evaluation. This is Mr. Hopkins. He's at Johns Hopkins. He was actually an engineer who designed the Hopkins rod. No relation to me, unfortunately. But when we do our airway evaluations, what we're looking for from an ENT standpoint is, you know, what does the voice box look like? Is this happy? Is it healthy? Is it inflamed? The area above the tracheostomy tube, you can see the suprastomal area. There's a little kind of bowed in from that tracheostomy tube, but clearly widely patent, widely open. This doesn't have any suprastomal granulation. This is a safe airway. And if this kid was, you know, able to be cannulated otherwise, this is a super happy, healthy airway for me. When we go to the OR, one of the things we've looked closely at is anesthetic time. There was a lot of kind of concern and questions for a little while about anesthetics in young populations. And I think that a combined OR approach minimizes that. You can see from these boxes here, the 93 minutes on a combined EGD, flex bronch, and airway evaluation from ENT ends up about an hour and a half of OR time, as opposed to an hour and 45 minutes if you do these individually, let alone when you start adding the addition of PACU time, you know, recovery time afterwards, time off work for families. This is drastically a better approach than taking these kids to the OR 2 or 3 times on multiple OR days. And the reason we named this presentation Beyond the Triple Scope is because one of our focuses is beyond the triple scope. A lot of programs, as we've discussed, are very surgically driven. You know, you have a child with a trach. How do you get that trach out? What are your surgical procedures to do that? But those kids have become less and less in the United States population. There's still some centers where that's a lot of what they do, but out in the community, in the real world, you're going to have complex kids with syndromes that can't be decannulated. So one, really putting our arms around the medical and the other kind of allied service health lines to take care of these kids, but also beyond the triple scope in terms of even the operative setting. We go out of our way to coordinate other types of procedures, whether that's CT scans, MRIs. Our dental service line does these procedures in the OR with us very frequently. We do sedated hearing testing on these kids routinely. And the only way that works is if you can kind of organize your OR days in a unified manner and have surgical coordinators that work tirelessly to kind of make that happen. even, you know, it clearly makes my world crazy on a Friday when I have 2 OR rooms and a dental room, and I'm trying to coordinate 6 or 7 OR providers. But I think if it helps those families, that's the cost to the healthcare system that I'm willing to accept and an effort we're willing to provide. Because if it's not well coordinated, you waste a lot of people's time, because you don't want a dentist waiting around to operate. You don't want John waiting around to do a flexible bronchoscopy. You have to make sure they have other things to do while we're waiting on coordinating these things. And that can be just, I would recommend being patient as you build out this type of program in LA to understand there's some bumps along the way, but having people in the same place at the same time is key. And from a fun standpoint, the things that we're looking for in the OR are clearly all the other things. I'm a surgeon, right? I like to operate. I like to do cool stuff just like you guys do. So we're always looking for when we can address subglottic stenosis with a cartilage graft, you know, throwing a cap graft on for somebody who has a tracheocutaneous fistula or has some kind of anterior A-frame deformity. But we also like to do fun stuff like posterior grafting. You know, this is a kid with posterior glottic scarring, where traditionally you would see a posterior kind of glottic graft done, and before we can decannulate. But I think that one of the fun things to do, and we try to tend to, is the world is also moving away from a lot of airway reconstructions open, because we can do so much endoscopically now. So that's, again, a change in my kind of practice over the last 15 years. This, in my original practice, would have been an open airway reconstruction. Nowadays, we will manage this endoscopically. So we'll go in, we will lyse this posterior scar band endoscopically and do a cricoid split endoscopically. And after that's nice and wide open, we will place an endoscopic graft, and we will suture that endoscopic graft in place so it can't pop out. And traditionally, this kid would have gotten a stent with a trach or a left intubated for an entire week. With this sewn in like this, I'll just extubate this kid on the table, and they won't have to even go, you know, they'll go home in a day or two from the hospital, as opposed to 7 days of general anesthesia and sedation. So it's funny because it's way less, it feels less big than an open airway reconstruction. But in the end, the graft looks great, vocal cords are wide open, and I've avoided a large open airway reconstruction. So from a surgical standpoint, it's a little, it's not as sexy as an open airway reconstruction, but we're moving so much more endoscopically. Not only do we partner drastically with our pulmonary team and our GI team, we work really closely in Cleveland with our cardiothoracic service line. Hani Najam is a magician from a surgical standpoint. And a lot like John is the diagnostician in a lot of my ORs, I'm the diagnostician in some of Dr. Najam's ORs. Like, you know, when we do a tracheal ring surgery, we're scrubbing in and we're doing these cases together. But if I'm being honest with myself, he's the one splitting the chest. He's the one putting the patient on cardiac bypass. Me and him are sewing a tube together for 5 minutes, but 90% of the case is our cardiothoracic team. And we get to manage that afterwards from an airway evaluation standpoint, along with Dr. Carl in the OR with us as well. That's what this would look like from a slide airway reconstruction standpoint with the cardiothoracic team. Here you see another time we would partner with our cardiothoracic team and our pulmonary team. When we're doing an airway evaluation, we're always looking for multi-levels of obstruction. This is an innominate artery obstruction. When I look with my rigid scopes, it's hard sometimes to get the patient in the right sedation level to see the dynamic exam. And again, this is why it's so important to partner with pulmonary, because they can look at this on a little less sedation when the child is breathing more avidly and more vividly, and you can see how much collapse there truly is in the trachea, because that can help decide when do we need our cardiothoracic team to perform an aortopexy, like what you see on the right there. So that's the same airway after it's been pexied up. And very similar with our laryngomalacia. You know, these are kids that we all see in a pediatric otolaryngology clinic, and partnering with our pulmonary team in the OR, sometimes they can get a different view than we get with a flexible scope in their sleep, same as you and me do when we do a sleep endoscopy for sleep apnea. Sometimes we can get different views with flexible scopes than we can with rigid scopes. And clearly addressing this with a supraglottoplasty, either cold or hot, is a reasonable option. All kinds of other fun things we see. This is a fun case for a kid who came from a different aerodigestive center and was thought to have cord paralysis and had a trach. So this kid's 1 and 2 years old now when they come to us. and we scope them, and we realize that the reason they have a trach isn't cord paralysis. The reason they have a trach is because they have this giant follicular cyst that's causing that. So if you see, your mind goes originally to laryngomalacia, when clearly that follicular cyst is driving a lot of this kid's airway obstruction. Glottic webs found occasionally, especially in DeGeorge 22q deletion kids. Sometimes we'll encounter subglottic cysts, but really, I think the most exciting thing for us is when we get to this point, right? We have had a wonderful day. A lot of times we'll film the decannulation for a child, and it's super momentous for a family. And that video that we shot of Caden, that was, I think the decannulation is actually on that video, which is super cool. But this is one of my favorite times. When you go back and you close that tracheocutaneous fistula, super easy, boring procedure. They go home the next morning, take a drain out. But it's so rewarding to know you had a trach, you didn't have a trach, and I may never have to see this patient again. That's pretty cool from my standpoint. After, one of the things we've also built in Cleveland is ancillary service lines. We have a multidisciplinary clinic that does a lot of cool stuff, but we've also developed some ancillary clinics that partner with our populations. Dr. Swathi Apache and my PEDS-ENT team has built a voice clinic, and she sees a lot of these kids post-decannulation that still have a lot of voice issues. They have breathy voice, hoarse voice. So finding somebody to partner with a speech team that has some time and dedication to pediatric voice is very helpful. We work with the fetal care team closely when exits are needed or when preoperative kind of evaluations are needed for those discussions of airway management and trach prenatally. And also lots of partnership with our sleep medicine department from a moving forward. How do we deal with some of these kids now that Inspire is going to be becoming more of an opportunity? Is this a management strategy that we can employ for some of our cerebral palsy patients and patients who currently we don't have a lot of surgical options outside of a tracheostomy? I'm a strong believer that very soon, a lot of these kids with spastic quadriplegia and airway management issues, if it's an airway issue and not necessarily a secretion management issue, I think we're going to be considering an Inspire in a lot of these populations moving forward. So we'll need to continue to partner with them. So that's kind of all I have. Me and John are happy to answer questions. These are the other members or some of the other members of our team, our speech and our physical medicine rehabilitation partners and our social workers, our GI team. But lots of fun work going on and happy to answer questions.
Dr. Hopkins, Dr. Carl, amazing talk this morning. Really, really awesome what you built over in Cleveland Clinic. I remember as a resident, one of the lessons you taught me is whenever you put it in a trach, the first question you always ask is, how do I get this out? And that lesson has stayed with me till this day. I'm sure there's going to be tons of questions from all the attendings. So I'm going to open it up to the floor for questions.
That's a big ask, guys. Tons of questions. Like he's really putting you guys on the spot. I like it.
I don't know if Dennis was referring specifically to me or to everybody, but I do have tons of questions. First of all, thank you both so much for talking to us today and what you've done at Cleveland Clinic. It sounds really incredible, and it's wonderful to meet both of you and to hear more about it. I do have a lot of questions, to be honest, but I also don't want to, take over the Q&A session. So I'll just start with one question. When you first started the multidisciplinary clinic, did you have every member of the team? I know you said not social work, but in terms of speech, specifically in your program coordinator, were all of those things, did you get those in place before you started the clinic and before you started the team? Or was it something that came on like kind of one by one?
Well, since I'm the old guy in the group here, I can probably answer that because I was there at the inception. It was a process of evolution. Honestly, what I had to do was I found people in the GI group, in particular, who had a particular interest in kids with these similar disorders. The issue for most of the faculty, and particularly for junior faculty, was they're under a lot of pressure to maintain their RVU productivity, et cetera. And I think it's one of the things that, Brandon may want to comment on as well. It's really important when you're talking to other department chairs or division chiefs or whatever, is to go ahead and let them know that the only way that you can really viably look at this is not to look at, clinic revenue as an isolated thing. You need to look at service line revenue. So all the procedures that are being generated by this, all the radiology, and look at this in a population health model, you're going to do nothing but decrease the cost of care that, $200,000 to $400,000 that Brandon was talking about. So I think really it's convincing upper level medical management or surgical management perhaps that these are worthwhile efforts, as long as you try to consolidate and make the ambulatory space the most efficient, as well as the OR time most efficient. And then look at a broader than just the clinical revenue. Look at the surgical and the radiology revenue, et cetera. Brandon?
Yeah, it's like from an organizational population health model, it's a no-brainer. You keeping these kids out of the hospital, $400,000 per inpatient stay is ludicrous not to do this. But you're right, on an individual service line provider standpoint, especially the providers that aren't us. So, one of the things we've focused on from an individual standpoint is making sure we're getting billed appropriately for the time we do. So every visit that we see in these multidisciplinary clinics, it's a level 4 or level 5 visit for me, no matter what. Most of the time there's a tracheostomy involved, or a modified barium swallow from the sleep team, or a FEES or something like that. So, my productivity probably is less than a general clinic, but it's not drastically less. But the amount of downstream revenue this sends to my OR is crazy high. I think that the arguments that are harder to make, or not harder, but you have to make, are for GI in the clinic is GI's time, pulmonary's time, speech's time. They are going to take a hit from RVU from this clinic a little bit. Not a ton, but a little bit probably. Nutrition, some of these other service lines aren't as productive. So making sure you're billing level 3s, level 4s, making sure in the operating room you're getting credit for microlaryngoscopy and bronchoscopy when you're guys doing those, maximizing your billing. But then if I were to start out this program, I know I wasn't here when it started. Originally, this program, the nurse practitioner was kind of housed within ENT. I think I would definitely get buy-in from your program that there has to be some form of nurse practitioner management or care coordination management that really takes ownership in this. Like me and John, I can't be held responsible for knowing where I'm going to be this afternoon, let alone knowing where 250 patients are and doing that. It is a huge burden that has to be managed by these other providers.
Yeah, I would just comment a little bit that yes, it probably is a larger hit in the medical providers in terms of number of patients seen in a given clinic, but the lifestyle for the clinician is greatly enhanced because we have the nurse practitioner to go ahead and the care coordinator be the consistent force throughout this, so that we're not fielding questions that are taking 20 minutes or 30 minutes to answer in the interval between the actual clinic visits. It's inordinately time consuming. And, I've got an RT group deals with the durable medical equipment issues. So basically the way I've set it up or we've kind of framed it was that our advanced practice nurse practitioner and our care coordinator are the patient facing aspect of this, while the respiratory therapy group is the DME facing aspect. And they interface at an administrative level, but don't necessarily have to be constantly present in the flesh.
Yeah, and the other thing I would mention is that I've been part of several different multidisciplinary approaches, and the biggest difference in our program here is the flat, playing field that we operate on. I've been through several multidisciplinary teams where there's kind of a leader from above who mandates things from above. How we approach things here, and I think the reason our clinics are fun and people actually don't mind working in there is we know each other. We know what happens outside people's lives, and everybody's opinion matters. It is a very flat respect that goes back and forth, and there's no person that's more important in the part of that team, whether it's the pharmacist that's there, whether it's our social worker. What we've realized is that if you take any cog out of that wheel, my life sucks. And I like to go home and have stuff that happens outside of the hospital. So we make sure everybody feels ownership of that. And every time we have a retreat every 3 months, everybody is important and everybody kind of voices their concerns about how to make their life better in the clinic.
Dr. Hopkins, Dr. Carl, to dovetail along that, as as I've been here for a couple of years, I'm finding out one thing, and that hospitals are big businesses, right? And so everything has to make financial sense for them to approve. So have you guys looked at the finances and that on that downstream revenue that you guys generate from this PCAVS clinic and see how viable it is, and if there is significant cost savings?
John, I mean, I think you guys did that kind of before I started from
Yeah, we've not done it since probably maybe 7 or 8 years ago, maybe a little bit longer. And we showed, like I said, that 70% decrease in cost was largely from decreased hospital bed days. But I think that we had done on a couple of occasions patient surveys, patient satisfaction, HCAP scores, et cetera, are phenomenally improved. And I think the other thing I would say, neither one of us has said yet today, is get an administrator who gets it, who is willing to advocate for you to go ahead and put the administrative business chops together, and they can go ahead and track revenue and try to see what that does generate. We were able to do that at the inception. We had a couple of years where we had a downtime with the administrator in my department, which kind of became the administrative home. It was fairly weak, and quite honestly, it was 2 years of hell because I couldn't demonstrate, honestly, back to, and as the ratcheting up of RVU targets were, I didn't have data to give them, but we've now returned and have excellent administrative support. So choose your administrators wisely.
Yeah, and I think, Dennis, we track number of ED visits every year and number of hospitalizations every year for every patient that comes through. We should probably publish something on that, John. That's probably a good idea. But we track it for all of our abstracts, and that's something that's collected every time these patients come in. And what we saw from the National HCUPS Kids database is that on average, when you get admitted to the hospital with a tracheostomy, this is, long-standing trachs and just like for random admissions, hospital length of stay is 1.7 days. And the cost to the healthcare system is $250,000 every time these patients hit that. That's the median. The mean is $400,000. So every time you can keep these kids out of the hospital, that's 3 nurses that you could have paid for in your clinic every freaking year, or 2 at least.
Yeah.
So whenever we ask for resources, we're like, this is why you need to give us resources, because you save 1 hospital visit a day on 1 kid. And it's that entire FTE for a nurse is saved.
Yeah, I would just make 2 comments. One is, when you have an articulate parent of a child with these medical needs, make sure that they become a member of your patient or your family advisory committee, so they can advocate as a consumer to the administration, saying, no, this is a great return on investment of personnel time. We're the HAD entity because we're employees, right? The consumers are the ones that do it. If you have an articulate parent, it'll go a long way to doing that. The second thing is, although it doesn't, in the whole context, doesn't really make that much of a difference, I think, financially. But one of the things I would emphasize is that we maintain, although we have a unified chart, everybody has, we take excerpts from everybody's individual chart note, so that every of the disciplines, peds, ENT, pulm, GI, we all keep our separate clinic notes and are able to bill accordingly for those individual patient visits. And then that stuff is extracted and put into a unified document, which then is handed to the primary care physician of record. And that has also been a great satisfier. So number 1, get an articulate parent. Number 2, get a high refer, a pediatrician in your community who can say, oh my God, this is great, because now I have 1 document that I have even in an EMR that reflects everybody's thought process under 1 timestamp, and it's hugely beneficial to them. And when your referring physicians are happy, you can be a lot happier.
And one of the dovetail on that, I think one of the important parts about keeping it financially solvent is making sure everybody who has a different billing nomenclature has a note that they write. And we actually do it instead of under Dr. Hopkins note, it is a PCAVS otolaryngology provider. So that can be me, or I can rotate Dr. Droplis, Dr. Apache, Dr. Timish-Polsky into that clinic, and the provider schedule is the same. Nutrition has it, speech has it. That way it's a little interchangeable, and the more you make the clinic interchangeable from COGS, the less you have to cancel the clinic. So every provider, you want to have a backup provider for them. That way vacations aren't canceling your clinics, because these families, you know, if you have to cancel clinic, you can push them 2 or 3 months down, and that can be very dissatisfying for them. And also, you know, think about it, trying to lug a kid with a trach, a vent, suction to clinic. If you have to haul them to 7 different clinic visits versus just 1, like it's a no-brainer. It's, you know, it's crazy to ask a family with, you know, 3 kids, no car, and a trach and a vent to try to get to 7 clinic appointments, let alone 1, you know.
Yeah,
I
this
know
is
how
all
hard it
really
is to get my
helpful
kid to a clinic
information.
too. So
What did you say, Dennis?
I know how hard it is to get my healthy kid to a clinic, right?
Oh.
Lugging her under one arm, diaper bag in the other, right? So I can only imagine.
The second month we ran this program, one of the parents, it was one of those articulate parents, actually went to an administrator and said, these guys saved me $150 a month in parking fees.
Wow.
So that alone.
Oh, that's interesting. Yeah, I didn't think about that. And
Yeah,
what
In
else?
Los
definitely
Angeles,
something to
that
do.
would be $300.
Yeah. Do I
All right,
have
I know.
time for one more question,
Yeah,
Dennis,
go
or
ahead.
no?
Go ahead, Dr. Reddy. Yeah.
Just a quick question, and well, actually, this is, yeah, I'll just ask my quick question. What order do you guys do the triple scopes in? Does Palm go first, or does ENT go first?
Typically I go first because I need the patient to be really light. Often what happens is
Okay.
our anesthesiologist will place IV, they'll get under sedation, we'll lighten the patient so I can get airway dynamics. And then often Brandon's looking over my shoulder, and then when I turn the patient over to him, I'm looking over his shoulder. So we don't actually have to talk about or look at still photos. We know what each other is doing. So it's incredibly valuable to be able to have that, like I said, under same set of clinical circumstances too.
Yeah, that's our routine. There, you know, I think before every Friday, I go through the OR list on Wednesday, and I think this has been the way it works the best is when I build the OR list and build the OR order and then send it out to all the providers and all the ancillary teams. That way they know that order, because every once in a while it will be different. For instance, GI will call me and they'll be like, I got to get to clinic by 9 o'clock. And if that's the case, we'll put a tube in, we'll let them do their EGD or an LMA and let them do their EGD. I think it's the more the surgeon, the point surgeon, which I would expect probably at your place, Dr. Reddy, to be you, to take ownership of that OR day and make sure you know where everybody else is. Because the more you can do that, the more they'll give you. The more you show that you own that OR day and you're going to make good use of the time, the more people will keep giving you resources. And over, you know, now in our OR now, you know, our next step is making sure dental has an OR room parallel to me. That way, when I need dental to come in and do dental work, they can just walk over from their OR and do it, and then go back to their own OR where they're super productive. If I have to ask them to come in from an outpatient clinic, it's like it's a big bummer for their entire day because they can't be productive. So it's a slow build over time. Put a five-year kind of plan together and get a good partner. Get a good pulmonary partner is the first step, I think.
And and I just about to say to that end, I would say lean on your pulmonologist, because we're the people who handle the interval. Most of the kids come in and out of the hospitals because of acute respiratory issues superimposed on their chronic needs. And so we're the ones who have to handle with that APP to go ahead and handle the interval, most of the interval issues. So yeah.
And
please,
Dennis would automatically just admit them to the pulmonary service.
it's fine.
I haven't favored it.
A chance to go is a chance to cure, right?
Direct admission.
Yep.
All right. Hey, thank you guys so much for attending this morning's grand round. I thought it was very, very beneficial. I'm very happy you were able to share some of the lessons you guys learned with us. For all the participants, make sure you send the CME code to the phone number to record your attendance. Thanks again, Dr. Hopkins, Dr. Carl.
Thank
you guys have a
you
great
so
day.
much.
Have a good day. Welcome to the
Nice to
morning
meet
in
both of
California.
you.
It's almost lunchtime here.
Yeah.
Right now.